Thank you, George, for the introduction. And let me tell you that 10 years ago, when we started implanting Kerarings and other kind of intra-ring segments, our professors from that time, they used to tell us that rings were not a refractive procedure. But let me tell you that during the last years, when we use the cornea rings in combination with the femtoseconds laser channel, and besides, with the option of implanting a phakic IOL, probably this procedure today is a refractive procedure. So what I'm going to talk during this presentation is the sequential intra-ring segment implantation and the options to use an anterior chamber IOL for the treatment of keratoconus and high myopia. As you know, there is a concept, which is the corneoplastic concept, where we as surgeons have the option to remodel the cornea without using any invasive procedures such as penetrating keratoplasty and lamellar transplant. And the aim of these procedures are to improve the optics, topography, optic performance, and of course, we need to reduce the refraction as well. When I was in my corneal fellowship 20 years ago with Roger Steiner at Tufts New England Medical Center, besides the diagnosis of keratoctasia with the early stages of topography analysis, we only have, as many others said, contact lenses, adaptation, spectacles, and we need to wait until the penetrating keratoplasty with the corneal scarring of the patients to perform a complete transplant. But today we have many options. As you mentioned before, the cross-linking, intrastromal rings, topo-guided photoablation, bulk, and phakic IOLs. So today I think the combination of intrastromal rings with phakic IOLs can give us the option of the refractive treatment in patients with keratoconus. This is our flow chart, therapy decision 3, and this is probably what we were using today in our clinic in Mexico. If we have a no-progression and an acceptable visual acuity with no scar, spectacles and contact lenses still are useful for the treatment of these patients. If we have an unacceptable visual acuity and scarring, definitely the way to go is DALC with the standard treatment, or DAL assisted with femtosecond zigzag technology with the interlace. If we have mild progression and acceptable visual acuity, probably the cross-linking is the best way to go. However, if we have progression, unacceptable visual acuity, no scarring in the central cornea, and irregular astigmatism, contact lenses, intracorneal rings, intraocular lenses, phakic intraocular lenses, or laser, topo-guided laser ablations, alone or in combination in between are good options not only to perform the corneoplastic effect in this very diseased cornea, we can also try to treat the refractive component that, as we know, is important in patients with keratoconus. Probably in the past, the pioneers in using the intracorneal rings, we knew that when we were using, for example, other kind of rings, such as the Intacs, and we face this into a patient with a -10 of a spherical component, we were only able to or capable to treat 2 diopters, and that patients felt very, very unhappy because residual myopia was -8 or -7. We have new technologies or new techniques for cornea transplantations, and there is no doubt that they offer better approach to these patients and less risk. We have the big bubble technique, but however, these patients usually takes, even if we use the big bubble, they take more than 18 months to recover, and usually the refractive error is not guaranteed. These patients will require probably a laser procedure, either a PRK or LASIK, and then we have this option to combine a ring and a phakic IOL of your choice. Can be an ICL, toric ICL, or in this presentation I will show you the results of 10 patients that receive in combination, first the intracorneal ring, and 6 months later the cachette anterior chamber intraocular lens. And these patients recover very, very, very fast, as you see, usually in a period of 6 months of time. This is an example of a patient that had that received 90 degrees intracorneal segments, 300 microns thickness, and 6 months after, he received an acrosoft cachette. Preparative best-corrected visual acuity was -8, axis 45, 20/50 best-corrected visual acuity, and after the procedure, 12 months after the procedure, first the rings to correct the stigmatism, and 6 months later, the cachette IOL to correct the spherical component of the refraction, and we achieved 12 months later, +1, -1, axis 50 for best corrected visual acuity of 20/40. This communication from Star Surgical, from a case that have the same situation. He had a compound myopic astigmatism. This patient received the intracorneal segments, and several months later, an ICL was implanted in order to improve the refractive component of this refraction in a patient with keratoconus, and the patient achieved 100% satisfaction. Which are the clinical pairs when we calculate the IOL for these difficult patients? Well, we suggest to use the same parameters workup and calculation as in the standard ICL implantation. However, where refraction in keratoconus eyes is difficult, we suggest to calculate with the subjective refraction, which provide the best vision for the patients. When the refraction and keratometry cylinder agreement, we suggest to implant the toric ICL only in those patients where the axis of the astigmatism amount of the refractive and keratoconic cylinder are agreed, and we indicate an spherical ICL in those cases where there is no agreement and only the spherical myopia value is high compared with the astigmatism value. Of course, patients need to have more than 3 millimeters of anterior chamber keratometry. The best cases, of course, are when we use this procedure for patients under 55 diopters in order to reduce, because if not, we will reduce the predictability in terms of calculation. Well, I suggest you to take a look to this paper that was published last year, November last year, and I think Pepe Alfonso was the first brave ophthalmologist in the world to say or to conclude that sequential intracorneal ring segments and a posterior chamberal implantation plus corneal relaxing incision provide good visual and refractive outcomes, indicated that this is a predictable procedure for refractive correction of keratoconus. So this is the first time that an ophthalmologist is so brave that he published in the most prestigious journal of our specialty, saying that we are able to treat keratoconus as a refractive procedure when we combine these techniques. I have experience using the combination of the intracorneal rings and the ICL. What we suggest is first to perform the corneal rings, and whenever we feel we have a stable topographic and refractive result, and this is probably achieved 6 months after the procedure, you can go ahead and use the anterior chamber or posterior chamber phakic IOL of your choice in order to treat the refractive residual the residual refraction of these patients. So in this small research or study that we use the sequential Keraring implantation and acrosoft cachette for keratoconus treatment, we use inclusion criteria, eyes with keratoconus that has sequential eyes intracorneal ring segments implantation and anterior chamber phakic intraocular implantation using the cachette IOL. The inclusion criteria all were keratoconus, contact lens interlens, and clear cornea. Maximum keratometry suggested was 55, and minimum keratometry reading and more than 40 diopters, and minimum corneal thickness more than 400. And this is the SI5 technique, use of the intralace. There is no doubt. My parameters is 80% of the corneal thickness in the area of implantation. I really like to have very tight channels. If we really want to achieve the corneoplastic concept, if we really want to accomplish it, I really suggest to use tight channels. So I use 4/8, 5/3 inner diameter, outer diameter. the entry cut length in between 0.90 and 1 millimeter of extension, and as many have mentioned, I use the steepest meridian to complete the dissection. As you know, the interlace provides us in 5 seconds dissection of the circle or the ring dissection you just saw using this handheld keratometer, the regular shape in the cornea, and this is an asymmetric technique using 160 one side 90 degree segment in the other area of the cornea, and this is the control image the day after. For those of you who are afraid,
Francisco, please, 1 minute more.
For those of you who are afraid about the night disturbances, I suggest 6068 using the interlace for your IS6 segments. If you are afraid about night vision disturbances, I only will take 1 minute. And this is the video of this technique. We are using here 6 millimeters inner diameter, 6.8 outer diameter for implanting this larger optical zone intracorneal segments. It takes a little bit more, only 8 seconds, and this is a dissection created by the interlace. And here, this is one of the examples where we have a compound myopic astigmatism. When we have high spherical component, high astigmatic component, we treat first the astigmatism with the rings, and later on we use the segments. This is a video where we combine the rings to treat the astigmatism, and 6 months later, we use the cachette intraocular lens anterior chamber phakic IOL for the treatment of the spherical component of refraction. So combining the use of femtoseconds, rings and segments, we are able to reduce the spherical component in these 10 series of patients. This is an example. Of course, even though that the outer refracting is the best way to analyze, in these patients he has -20, -4, and we were able to reduce to -0.5, -3/4 of cylinder for a good result and achievement of the corneoplastic. Not only the corneoplastic concept, we were able to treat the refractive component of this difficult patient. So in conclusion, sequential Keraring and anterior chamber phakic IOL provided good visual and refractive outlook, indicated that it's a predictable procedure for refractive correction and keratoconus. So during the last 10 years, the therapy of keratectasia has undergone the change in paradigms. PKP or DAC is appropriate only for advanced cases with ESCRS, and definitely the stromal wrist and phakic IOLs are a good option to treat not only the corneoplasty for these patients, we are able to treat the refractive component of this disease. For your attention, thank you so much.